Physicians. The Caribbean College of Family Physicians, Jamaica chapter, is proud to share a glimpse into the work we're doing to support and elevate family physicians in our. Good evening, colleagues. It's a pleasure to be with you this evening as we highlight some important information about the Caribbean College of Family Physicians. The Caribbean College of Family Physicians, Jamaica chapter, is proud to share a glimpse into the work we're doing to support and elevate family physicians in our island state. Let me begin with a brief overview. The Jamaica chapter is one of the founding arms of the Caribbean College of Family Physicians and currently includes over 300 members, many of whom remain actively engaged. Our chapter plays a pivotal role in both clinical and educational outreach and serves as a cornerstone for continuing professional development, member engagement, and advocacy. In addition to organizing CME activities and professional networking opportunities, we actively advocate on behalf of our members and the broader healthcare community. Our advocacy efforts include collaboration with the Jamaica Tobacco Control Authority, the Heart Foundation of Jamaica, the Medical Association of Jamaica, the Jamaica Fair Trading Commission, and various health insurance providers with whom our physicians conduct business. Through these strategic partnerships, we aim to ensure that the voice of family physicians remains influential in shaping national health policies and standards. Over the years, we've led or partnered in several key initiatives. We have collaborated with JVMA for the annual One Health Conference. Every May, we co-hosted the World Family Doctor Day celebrations with the Association of General Practitioners of Jamaica and the Family Medicine Department at the University of the West Indies, Mona. Our annual event brings together over 900 plus physicians and other healthcare professionals from across the region. Annually, we have organized more than 20 CME sessions, both virtual and in person, on topics ranging from mental health and primary care to cardiovascular updates, ensuring our members stay current with evidence-based practices. Additionally, our website has a blog and newsletter platform to highlight family medicine voices across the Caribbean and provide a platform for scholarly work and opinion pieces. We continue to host our own website, ccfpjamaica.com, where information can be easily accessed. We are one of Jamaica's leading professional associations, accredited by the Medical Council of Jamaica, MCJ, to organize continuing medical education, CME, activities on behalf of pharmaceutical companies and other organizations seeking accreditation for their educational events. We have expanded our CME offerings through an on-demand e-learning platform. We actively participate in a range of outreach initiatives, including health fairs, the refurbishment of facilities for persons with disabilities, and the provision of furniture, medical equipment, and pharmaceuticals to homes for the elderly and disabled. These are just a few examples of the impactful work being carried out by our chapter, made possible through the dedication and collaboration of our members and the support of an efficiently managed secretariat. What keeps our chapter strong is our commitment to inclusivity and relevance. We actively reach out to both seasoned practitioners and new graduates through the FAMED unit at UWI Mona and at our CME conferences. Membership is open to all physicians. There are different categories of membership on our website. Our CME events also offers the opportunity for physicians, nurses, and allied health professionals to gain CME, CPD for their annual renewal of their practicing license. We create mentoring spaces, WhatsApp communities, and free access to accredited CME sessions. We also recognize that our younger colleagues are looking for more than certificates. They want mentorship, representation, and purpose. That's what CCFP offers. For the upcoming year, we're looking toward greater initiatives. That is why we are encouraging you to join our organization. New members, new ideas, new beginnings. We encourage our existing members to re-engage as we look towards exciting times ahead for the Caribbean College of Family Physicians, Jamaica chapter. We need you new members, returning members, and future leaders. A number of our members can and will share with you why they personally joined CCFP. It was the sense of belonging they felt. They realized they were not just a GP in their own practice. They were part of a regional network of professionals who understood challenges, have shared values, and were committed to advancing family medicine in the Caribbean. With that said, we invite you to join us. Not just for CME credits, but for community. Not just for events, but for impact. Because the college is only as strong as its members, and your voice matters. Thank you, and we are happy to speak with anyone interested in joining or renewing their membership. We're stronger together. Good evening, colleagues.
All right, thank you guys so much for joining. Good evening, good evening. And I'll hand you over to our moderator for this evening session, Dr. Aileen Standard Wilson. Have a wonderful event.
Good evening, all. On behalf of the Caribbean College of Family Physicians Jamaica chapter, I welcome you to this evening's Women's Health webinar on the theme Silent Struggles, the Overlooked Burden of Sleep Apnea on Women's Health and Mental Well-Being. As you heard, I am your moderator, Aileen Standard Golson, and I will be guiding us through this evening's presentation, which I am sure will be an enriching one for us all. As we begin, I would invite one of our CCFP Jamaica chapter executive members, Dr. Anna Brown Morgan, to lead us in prayer.
Good evening, colleagues and friends. Heavenly Father, as we gather for this conference this evening, we ask for your guidance and wisdom. Illuminate our minds, open our hearts, and grant us clarity as we learn and share. May your Holy Spirit be present in our discussions and interactions, leading us to new insights and a deeper understanding of your truth. Dear Father, help us to listen to one another with open minds and to learn new perspectives. May our time together be a blessing to all, and may we grow in knowledge and understanding, and may what we learn here contribute to the betterment of our own and our patients' lives, and for the advancement of your kingdom. In Jesus' name we pray. Amen.
Amen. Thank you very much, Dr. Brown Morgan. At this time, I would invite us to pay attention to a message from the President of the Caribbean College of Family Physicians Jamaica Chapter, President, Dr. Seni Ananuju, who will bring greetings and an overview of this evening's proceedings. Dr. Seni Ananuju.
Good evening, everyone, especially invited guests, Dr. Sterry Baker and Jordan Eaton, moderator Dr. Aileen Standard Golson, esteemed colleagues, sponsors, friends, ladies and gentlemen, a pleasant good evening to you all. It is indeed my pleasure and honor on behalf of the Caribbean College of Family Physicians Jamaican chapter to bring you greetings and welcome you to this evening's CME accredited clinical meeting, main focus, silent struggles, the overlooked burden of sleep apnea on women's health and mental well-being. One cannot ignore the important but oftentimes overlooked role that sleep plays in the optimal maintenance of both physical and mental health. It has also long been recognized that sleep forms an integral part of the recovery process during periods of ill health. Sleep apnea is a serious condition which can be central or obstructive and can impact negatively on an individual's physical and mental health, affecting their daily activities. Obstructive sleep apnea is a common disorder with a prevalence ranging from 2% to to 50% in men and 2% to 23% in women, depending on the study and the population. The prevalence tends to increase with age and obesity. Prevalence in male is higher than female, and it is usually underdiagnosed and linked to other comorbidities such as hypertension, diabetes, and even cancer. The Caribbean College of Family Physicians is an organization with local and regional links whose primary mandate is the enhancement of knowledge and skills of doctors through various media, as well as the co-organization of webinars with other organizations. It is hoped that we will, at the end of this evening's presentations, expand our knowledge and clinical management of our patients with sleep apnea. And this evening, we are privileged and pleased to have with us from our very own Jamaica, two well-known and experienced speakers, consultant pulmonologist, Dr. Terry Baker, and psychiatrist, Dr. Jordan Eaton, to share their insights as we delve deeper into matters surrounding sleep apnea and its intersection of both physical and mental illnesses with a focus on our female population. The college is this evening very grateful to them for sacrificing their time to share their talent, knowledge, and expertise with us. Dr. Baker, Dr. Eaton, a warm, wholehearted welcome to you both. I have no doubt that we will be well informed and enriched by your presentations. I also wish to extend a heartfelt gratitude to the members of the college and all other attendees who are present. We are well aware that the choices are many, and we are immensely grateful that you have chosen to spend your time with us. A sincere thank you to our secretarial staff, headed by Ms. Lynn Thompson Hyatt, and IT team headed by Mr. Samuel Aaron of Old Gate Solutions Limited. To our sponsors, Indus Pharma and Abbott Nutritional, we say thank you. It takes cash to care, and we are truly grateful. Finally, thanks to Dr. Anna Brown Morgan, Executive CCFP Board Member, for her opening invocation, and Dr. Dane Levy, the college's Honorary Secretary, who will be delivering this evening's official vote of thanks. On behalf of the college, I thank and welcome you all for attending, and I invite you to sit back and enjoy the presentations. Thank you, and as always, God's richest blessings.
Thank you so much, President Seni Ananuju, for those opening remarks. As we get ready to go into the meat of the matter, let me remind you that there will be a question and answer session at the end of the evening's presentations. But as we go through, there is a tab at the bottom of your screen marked Q&A. You could put your questions in there, indicate which speaker the question is for, and when we get to the question and answer session, we will have these questions answered. So please remember, any questions in the Q&A tab. It is my great pleasure now to introduce to you Dr. Terry Baker, who is an internist and pulmonologist who completed undergraduate medical studies and postgraduate studies in internal medicine at the University of the West Indies, Mona. She did her clinical fellowship in pulmonology at the University of Toronto, Canada. Dr. Baker is currently the Senior Medical Officer of the National Chest Hospital, Jamaica, where she leads a team of medical and paramedical staff. She has responsibility for inpatient and outpatient medical care service delivery, budgets, and program implementation. She's an associate lecturer in the Department of Medicine, University Hospital of the West Indies, and an examiner of both undergraduate and postgraduate candidates in medicine. Dr. Baker works in both the public health sector and in private practice as an internist and pulmonologist. She is a member of several professional bodies, including the Association of Consultant Physicians, Jamaica, the European Respiratory Society, and an affiliate member of the American College of Chest Physicians. Her duties extend beyond hospital administration and public-private consultation. She is actively involved in research and educational programs for varying groups of health professionals and the public, with a special interest in asthma, COPD, tuberculosis, lung cancer, and anti-smoking advocacy. She has an avid interest in sleep medicine. Dr. Baker has presented extensively throughout Jamaica and overseas in the Caribbean and the United States of America. She is motivated, driven, and actively seeks to expand horizons while ensuring equity and quality health care. We are very excited to welcome her this evening to present to us on the silent epidemic, understanding sleep apnea and its impact on women's health. Dr. Baker, over to you.
Thank you, Dr. Standard Goldson. Thank you for that welcome. And let me thank the CCFP for this invitation. This is an area that is particularly dear to me, and more I'm recognizing, as Dr. Ananuja had said, how important sleep is. This thing that we used to learn, that sleep is not necessary. You sleep when you die. You have to stay up and get things done. We recognize now that sleep is integral to our health. And as women, sleep is even something that, because of demands of home and profession and etc., we sometimes leave things till last, but recognizing that a paucity or inadequate sleep actually has a significant negative impact. So I'm going to share my screen. Let me just put this on. And we're going to be looking at sleep apnea, particularly in women, looking at the awareness, diagnosis, and a bit of treatment. And this is because for so long, sleep apnea has been thought to be a condition that affects primarily men, and primarily men that are overweight. And because of this, the women have been, for want of a better term, a bit ignored. And it is also because the so-called typical symptoms that we associate with sleep apnea may not present as such in women. So by the time we're finished, I'm hoping we can understand a bit more what sleep apnea, but particularly obstructive sleep apnea is, look at its prevalence and the risk factors, particularly as it pertains to women, look at the symptoms and diagnosis, what are the health implications of untreated sleep apnea in women, and what are the management and treatment options for women in particular. So when we speak about sleep apnea, particularly obstructive sleep apnea, we recognize that it is a complex disorder. And it is complex because we are learning so much more about the whole physiology of sleep and the pathophysiology of the various sleeping disorders. So obstructive sleep apnea is the most common sleep disorder out there, and it is characterized by having either a partial or complete collapse of the upper airway, which occurs during sleep. And this may be due to a number of factors. There's one, the change in the airway muscle tone that occurs in sleep. So I often say our bodies relax, all of our muscles relax, but so too do the muscles of the upper airway relax, which causes a narrowing of this airway. In persons who have obstructive sleep apnea, the narrowing is significant, and this will lead to intermittent episodes of hypopnea. Hypopnea is a reduction in airflow, 30% or more below what we expect it to be, lasting 10 seconds or more, or an apnea, which is a complete cessation of breath. Pathophysiologically, we're looking at a more than 90% reduction of airflow. But in other words, both a hypopnea and an apnea are associated with significant falls in airflow, and with this, an associated significant falls in the oxygen levels. Now, if we were awake and having difficulty breathing, and our oxygen levels were falling, particularly to low levels, we would be aware of this. But because persons are asleep, many times it goes undetected. And so with this, obstructive sleep apnea is usually a chronic condition, and it results in other chronic morbidities that will affect particularly the cardiovascular, pulmonary, and neurocognitive systems. So this is just a diagram showing what I was speaking about. The upper diagram shows a patent airway with the blue arrows representing airflow. And this person does not have obstructive sleep apnea, air is flowing. But in the lower diagram, during sleep, particularly sleeping on the back in the supine position, there is the gravity pull of the tongue backways and the collapse of the soft tissues of the palate with subsequent obstruction of the airflow. And this is a person who often will be snoring or gasping or choking or even stop breathing, as witnessed by the bed partners during sleep. So the pharynx itself is a hollow structure, and it is prone to collapse. Now we have opposing forces. You have the soft tissue and the bony structures that increase intraluminal pressure, leading to an anatomical collapse during sleep, right? And then you will have the dilator muscles, which maintain patency usually through reflex neurological pathways, and this is the non-anatomical aspects of what happens during sleep apnea. So you can have disturbances either with an anatomical pathway or a non-anatomical pathway, and contributions from both that will subsequently lead to obstructive sleep apnea. The snoring that is heard, okay. This has just frozen. So sometimes, just give me a second, please. Don't know why it has frozen. Sorry. Share once again. Okay, there we go. So the pathogenesis is multifactorial. So as I mentioned, there may be alterations in both the anatomical or structural structures of the upper airway. And associated with this is often a crowding of this upper airway. So many times in examining our patients, we take the neck circumference, you ask the patient to open their mouths, you're looking at their tongues, you're looking at the posterior or pharynx, and I will look at a patient, and I think we might remember when we speak about the Mallampati score, and say to the patient, do you snore, right? Because it is, if they are awake and it already looks narrowed, you can imagine that when they go to sleep and they lose this muscular tone, it's going to be even more narrow. And then the air flow through this narrowed passageway is turbulent, and that is what produces the snore. So crowding of the upper airway can occur in tonsillar hypertrophy, in a patient who has retrognathia. If there is increased peripharyngeal fat deposition, usually these persons have a larger neck size and shorter necks. There may be craniofacial anomalies that may be seen, just patient being born like that, small airway size. Patients who have had trauma to the face as well, even a deviated septum, can have anatomical or structural conditions that will predispose them to developing obstructive sleep apnea. Then the alterations in the non-anatomical factors include ineffective pharyngeal dilator muscle function, a lower threshold for arousal because of airway narrowing, and just an unstable control of breathing. This just underscores that it's not just a case of, oh, the person's airway is crowded and they're obstructed, but there are usually a number of factors at play. And so for the person who has obstructive sleep apnea, they may complain of fatigue. They're just tired, they sleep, they're awakened, they wish they could stay longer in bed. And this feeling of fatigue and lethargy continues throughout the day. Many persons will say, but doc, I have no problem falling asleep. I can fall asleep just like that. Many times give me a chair to sit down and I'll fall asleep. And I'll say to them, that is not normal to be falling asleep so readily, so easily. There's the excessive daytime sleepiness, somnolence, unrefreshed sleep I mentioned, snoring. Many of the patients or most persons will snore, and then the witnessed apneas. So you have the bed partner or persons at home who will say, yes, doc, she stops breathing during sleep, or yes, he stops breathing, and I have to nudge him or nudge her. Or then you have some persons who just watch, and I'm wondering, so you're watching the person not breathing. The frightening thing, it is a frightening thing for many persons, but the reality is that they will start to breathe again. There's a nocturnal gasping or choking, particularly as they're going off to sleep. Many persons awaken with headaches that will last throughout the day, palpitations, memory impairment, the brain fog, just not remembering where things are, having to triple focus on doing tasks that usually would have been so easy, and nocturia and erectile dysfunction. So there are a number of symptoms that can occur, and not everyone will have all. But if they have a heightened sense of awareness that persons who present with these symptoms, while they may be attributable to other conditions, we need to remember that sleep apnea also can cause any one or more of these. So some of the factors that are associated with obstructive sleep apnea: gender, yes, we often see it more in males than females, although the postmenopausal woman has a 2 to 3 times increased risk and actually approaches the number of incidents that we see in men. Persons who are overweight, particularly greater than 35 BMI, but it has been estimated that persons with a BMI of over 40, at least 40% of them will have obstructive sleep apnea. That being said, I have patients who are of normal BMI who also have sleep apnea. So this misconception that it is only persons that are overweight can have obstructive sleep apnea is far from the truth. Increasing age, race, persons of Asian descent and Blacks are at an increased risk of having obstructive sleep apnea. There's a family history. Many patients will report other siblings or parents who have sleep apnea. And then the interesting thing I find is that many persons say, well, doctor, can't sleep. What many persons think maybe insomnia may actually be sleep apnea, but then they're taking sedatives and other agents to assist with sleep, which invariably may make the obstructive sleep apnea worse. Now, if left untreated, sleep apnea can increase the risk of health problems. It does significantly increase the risk of morbidity and mortality. Now, sleep apnea in and of itself won't cause death, but it is the associated morbidities with it that can cause death and even sudden death. So there's increased risk of hypertension, heart disease, particularly arrhythmias. Many patients who I have tested for sleep apnea, their presenting complaint is that of palpitations, myocardial infarction, and sudden death, usually on the background of an arrhythmia. Diabetes, stroke, depression and anxiety, and this is a very complex relationship between mental health and sleep apnea. Erectile dysfunction in men. Many of my male patients at first may not bring this up, but in having the discussion with them, oftentimes you see them nodding their head like, yes, doc, they are witnessing some amount of erectile dysfunction. And while many think that is, oh, they're getting older, they do recognize that this, of course, is of grave concern. Loss of libido in women as well, worsening of ADHD because children too have sleep apnea and may be labeled as, you know, a troublesome, restless child, a slow learner, when it is indeed undiagnosed sleep apnea that we're dealing with. I did mention headaches, seizures, and then there's the increased risk of accidents, not just for persons who drive, but also for pedestrians. They are tired, they're sleepy, they're not focused, they're more likely then to step out into the path of an oncoming vehicle. It's interesting that we don't have the laws yet, as far as I am aware, within the Caribbean, but in North America, pilots, bus drivers, and lorry drivers who are diagnosed as having sleep apnea are expected to, one, for it to be reported as a medical condition, and there are medical legal consequences of not reporting it. And then these persons have to be treated to continue with their jobs and profession. So it's increasingly being recognized as a major contributor of cardiovascular morbidity, including heart failure and acute coronary syndromes, and the various arrhythmias such as atrial fibrillation. You do have pulmonary manifestations, which include the development of CTEPH, which is chronic thromboembolic pulmonary hypertension in our patients, which can then lead to right-sided heart failure, shortness of breath, and respiratory failure. And then there are the neurocognitive morbidities, which include stroke, neurobehavioral disorders such as depression, and aggression, anxiety, and cognitive impairment. So let us focus more on women. So let us look at the prevalence and risk factors, particularly in women. So as I mentioned at the beginning, it is a common misconception that sleep apnea primarily affects men. But studies have shown that women are also significantly impacted. In the adult population, obstructive sleep apnea is more prevalent in men than women, and the estimated prevalence in women is mild obstructive sleep apnea, about 9 to 17%, moderate to severe, 5 to 9%. So when we compare this to men, men have nearly a 2.5 to 3 times increase in prevalence for both the mild and moderate to severe sleep apnea. But when we get to the menopausal women, we see where the numbers actually increase. And there are age-related changes of obstructive sleep apnea in women. Premenopausal, there's more estrogen and progesterone on board, and it is believed that these hormones do offer a protective effect. In the postmenopausal women, when there's a decrease in estrogen and progesterone, we see where the prevalence increases significantly and may actually approach the prevalence of men in a similar age group. So with this, there needs to be a heightened awareness and interest to look out for this in women, diagnose and treat, because we remember the risk factors associated with OSA. When we look at women, obesity is the most significant modifiable risk factor. In the postmenopausal women, with the loss of estrogen and progesterone and slowing of metabolism, there is an increased risk of having central or abdominal fat deposition, and also fat deposition within the neck, which then increases airway collapsibility. And it is shown that women who have a BMI greater than 30 are at a significantly increased risk. And believe you me, it is not difficult to gain a BMI of 30 or more. The postmenopausal woman has a 2 to 3 times higher risk of obstructive sleep apnea compared to the premenopausal women. And a lot of this, as stated, may be due to the loss of the hormonal support. Looking at the premenopausal women, let us look at the pregnant women. Now, the risk in pregnancy increases in the 3rd trimester, and this may be due to a number of factors: the associated weight gain, the fluid retention that occurs many times in women during pregnancy, and the associated hormonal changes may lead to edema of the airway and an increased risk of obstructive sleep apnea. And this is particularly higher in women who have gestational diabetes, obesity pre-existing the pregnancy, and preeclampsia, which occurs during the pregnancy itself. So we have looked at hormonal changes, and as I mentioned, lower estrogen levels and lower progesterone levels may lead to an increased risk of developing obstructive sleep apnea. Lower progesterone levels may contribute to OSA because usually progesterone is there to stimulate respiration. So when the levels fall, there is that loss of stimulant right there for the person to breathe. And actually, in some conditions, we do give patients progesterone to stimulate respiration. PCOS, or polycystic ovarian syndrome, is associated with an increased risk due to insulin resistance, excess androgens, and obesity, and again, the hormonal changes that occur. It has been shown that women may have more REM-related obstructive sleep apnea, which is often harder to detect using the standard sleep studies. And women are also more likely to have what we call sleep fragmentation, that is more frequent arousals and insomnia-like symptoms compared to their male counterparts. So a number of women present and it's thought to be insomnia when on further investigation, we actually recognize that it is sleep apnea, but they may not have the chronic fatigue and the loud snoring as seen in their male counterparts. Other risk factors for obstructive sleep apnea in women would include a family history, smoking, which leads to now inflammation and edema of the upper airway, the use of alcohol or sedatives, and it is surprising the number of women who are on a small dose of benzodiazepine in the evenings. Oh, doctor, just use it to help me relax, and not recognizing that it very well may be contributing to their fatigue, chronic fatigue that they are experiencing. The craniofacial anatomy and thyroid disease are also associated with development of obstructive sleep apnea in women. So the symptoms in women may differ compared to that in men, and particularly in our postmenopausal women who may be complaining of insomnia, chronic fatigue, may be diagnosed as having depression or mood disturbances, and they're told, oh, you're just going through menopause. And while it may be associated with menopause, it may jolly well be due to the obstructive sleep apnea, which if diagnosed and treated, that person will be doing much better and feeling much better. There's an increased risk of having daytime sleepiness, restless leg syndrome, morning headaches, and poor concentration compared to their male counterparts. So let us focus a little bit more on some of the conditions. When we look at menopause, it is felt that 20% of women actually develop obstructive sleep apnea during this period. And again, it is due to the hormonal changes that may occur, both of which have been shown to support respiration by different modalities. So when we lose these hormones or the decrease in levels of these hormones, we're increasing the risk of developing sleep apnea. And with this declining hormone levels, there is a decrease in muscular tone, breathing becomes less stable, and all of this leads to the risk of and increase in severity of obstructive sleep apnea. Interestingly, women who are placed on hormonal replacement therapy are half as likely to have obstructive sleep apnea compared with postmenopausal women who are not. So that is some food for thought right there. It does underscore the importance of the hormones, and it may be a treatment option for a select group of women. Menopause is often associated with weight gain, whether this is due to slower metabolism, and then there's a fat redistribution that occurs, which loans itself to developing the condition. Menopause is often associated with hot flashes, night sweats, insomnia, frequent night awakenings, which causes sleep fragmentation, lighter sleep stages, where during this phase, apneas are more likely to occur, but are more often not noticed for exactly what they are. So the woman is waking up frequently. She thinks it may be due to her hot flashes, which may be contributing, but also the question is, does she have underlying sleep apnea? Looking at pregnancy, there's an increased risk of obstructive sleep apnea due to both physiological and anatomical and hormonal changes that occur during pregnancy. There's the associated upper airway edema and congestion. There is increased blood volume and capillary permeability, which may lead to fluid retention. And all of this can cause nasal congestion. Those of us who have seen pregnant women know that nasal congestion is quite common in this group. But with this, it may actually lead to narrowing of the upper airway and increasing collapsibility during sleep. So there may be an increase in progesterone, which during pregnancy, which increases respiratory drive, but interestingly in pregnancy, both estrogen and progesterone may also contribute to edema and airway obstruction, which occurs during pregnancy. So in later stages, this hormonal balance may favor actual airway instability, particularly in persons who may have been predisposed, such as a woman who may have been obese before the pregnancy, and increases the risk of developing sleep apnea. Weight gain, we have mentioned before, particularly in the third trimester, which will then loan itself to developing sleep apnea, and then the growing uterus, which is pushing up the diaphragm, causing a lower lung volume or less lung volume, reduced functional residual capacity, which may then lead to frequent desaturations during sleep and increased breathing instability. Pregnant women, especially in the late pregnancy, may spend more time sleeping on their backs because it is more comfortable, but this position actually increases airway collapse and can subsequently cause compression of the IVC, the inferior vena cava, reduce venous return, and affect respiratory dynamics. And with this is increased risk of preeclampsia, chronic hypertension, gestational obesity, gestational diabetes, which is at a higher risk in pregnant women who actually have sleep apnea. Because of the variations in blood flow and oxygen level, there's a risk of fetal growth restriction or retardation and an increased risk of cesarean delivery. So with all of this being said, in the postmenopausal women who are at increased risk, an increased risk of having cardiac disease, and in our pregnant women who are also at increased risk of having OSA and an increased risk of a rocky pregnancy or an unfavorable outcome, we need to have our antennae up to diagnose it and to treat it. Now, it follows the same principles as in men, but it should be tailored to female-specific factors, looking at pregnancy, looking at the menopause, and the variations in symptom presentation. The gold standard is still that of CPAP or APAP, as we use now for moderate to severe obstructive sleep apnea, which effectively is a pneumatic splint to help to keep the airway open so that airflow is normalized and the person can now breathe. It is equally effective in women compared as it is in men. Yes, there are challenges in using the APAP device, and we often say to our patients, give yourself 6 to 8 weeks of using the device. They have made strides in the devices are smaller, not noisy, and there are more masks available now, so it's not necessarily the Darth Vader type mask that used to be more common. The benefits is that it reduces daytime fatigue, blood pressure, and cardiovascular risks, and it does improve mood and sleep quality. Lifestyle modifications are particularly effective in more mild or moderate or used as adjuncts to other treatments. So even modest weight loss can significantly improve obstructive sleep apnea severity. And it is particularly important for our patients with obesity or those who have gained weight with the menopause. We advocate for positional therapy because sleep apnea is worse when supine, and therefore avoiding supine sleep may help. Supine sleep may actually worsen, or in patients who have what we call upper airway resistance, not necessarily sleep apnea, but a step before, it may then contribute to developing significant sleep apnea. And oftentimes there are devices or pillows that are used to ensure or to try to keep the person on their side rather than flipping over onto their backs. We speak about sleep hygiene, reducing alcohol and sedatives, especially near to bedtime. Preparing to go to bed is as important as preparing to do anything else. So, you know, you get up and prepare to go to work, you know what clothes you're going to wear, you're going to have your shower, you're going to put on makeup, you're going to have your breakfast. Well, you also prepare to go to bed and not just drop asleep, which many of us do. You're getting tired, or you're just going to lay down for a bit, and the next thing you know, you're sleeping for a few hours, you get up and your whole sleep cycle is disrupted. So we advocate sleep hygiene, preparing to go to bed. You have the 1, 2, 3 rule where you start to unwind in preparing to go to bed. Not taking any stimulants, not using anything with caffeine, not having a heavy meal before going to bed, but not going to bed hungry, and also unwinding. Not watching anything that is going to stimulate you. So even though I advocate, if you're going to bed at 8, 9 o'clock, I would not recommend watching the 7 p.m. news, sorry, because as far as I'm concerned, there is nothing there that is usually peaceful and calming. So maintaining consistent sleep schedules would be important. We have the oral appliance therapy, and these are devices that are worn within the mouth, usually fitted for the person, unique anatomy. And what these do is to reposition the jaw, pulling the lower jaw forward, pulling the tongue forward in an attempt to open the airway. This too may take a little bit of time to get used to wearing it. We use it for patients who may have mild sleep apnea or moderate to severe sleep apnea who may not be able to tolerate the CPAP machine. Hormonal therapy is appropriate for select cases. As I said, estrogen and progesterone replacement therapy may often offer modest benefits, but is not a primary treatment. And it's not recommended solely for OSA, but may be an adjunctive therapy in menopausal women who have sleep disordered breathing. So the first line treatment is still CPAP, which is safe and effective. Weight management, monitoring for gestational complications, and the oral appliances, which are not typically used during pregnancy unless prescribed with caution, but just to state that the CPAP is safe and effective in our pregnant patients. Looking at atypical symptoms, such as those women who their primary symptomatology may be insomnia, the depression, fatigue, and anxiety, instead of the loud snoring and apneas. Well, cognitive behavioral therapy for insomnia alongside treatment of obstructive sleep apnea may be warranted. So what is CBTI? This is an evidence-based program It is a non-drug treatment that helps individuals identify and change their thoughts and anxieties and behaviors, which would then interfere with sleep. And you have a number of steps with CBTI. It is looking at sleep hygiene, as I said, appropriate bedroom environment. Your bedroom is supposed to be your sanctuary. Your bedroom is supposed to be the place for sleep and intimacy. It is not a dining room. It is not a living room. You should not have televisions in the room because these screen-based devices, one, they may stimulate you to be watching various programs, and two, the light associated with these devices, even when you go to sleep, that light is stimulating your pineal gland and your brain is not being allowed to go to sleep. I've heard patients say, Doc, I can drink coffee at any time of the day or night, but persons who have sleep disturbances, we strongly recommend no caffeinated drink beyond 12, 1 o'clock within the day, not at nights. You use various stimulus control, putting down the television, putting down the tablet, putting down the phone, and when you do awaken, not to pick it up unless you're actually ready to start the day. Various relaxation techniques are employed. So this is a whole system that is used for patients in conjunction with traditional OSA therapy. So in conclusion, unfortunately, that stereotypic obstructive sleep apnea patient who is an overweight, middle-aged man is not true for everybody with sleep apnea. As I said, you have patients with normal BMIs, and research has shown that women also suffer from OSA, and the two particular groups are our postmenopausal women and our pregnant women. That being said, any woman may be at risk, particularly if they have some of the risk factors. Unlike men, women are less likely, however, to be diagnosed and treated, which puts them at a greater risk of developing the OSA-related medical conditions, including high blood pressure, heart disease, stroke, and arrhythmias. And just to underscore that women may experience different symptoms than men. And so sometimes the symptoms that we say are, oh, you're going through menopause, that's why you're not sleeping, that's why you're feeling tired all the time, may actually be due to undiagnosed OSA. And we owe it to our patients to investigate and treat them. It is estimated that 90% of women with OSA are actually undiagnosed. Thank you.
Thank you very much for that, Dr. Baker. You took us through a review of the mechanism of sleep apnea, the risk factors and health consequences of sleep apnea, especially in our postmenopausal women, and the holistic treatment of sleep apnea. Especially of interest was the cognitive behavior therapy for insomnia, new concept certainly to me. So thank you very much for that very comprehensive overview of sleep apnea and its effect on women. I'm going to remind those of us in the audience who have questions for Dr. Baker to put them in the Q&A tab, and later on we will address them. So once again, Dr. Baker, thanks very much.
Thank you.
As we all know, webinars, educational forums such as these are not possible without the support of sponsors. We depend on these sponsors to help us to meet the financial challenges associated with putting on a webinar of this kind, even in a virtual setting. So at this point, I want to give our sponsors for the evening a chance to share with us on their products. I am first going to invite Mr. Dan, we call him, Dayanandan from Indus Life Sciences, to share with us some information from Indus Life Sciences. Over to you, Dr. Dan.
Doctor, good evening, doctor. Thank you very much. I'll share my screen.
You should be able to do so.
Are you able to see my screen?
It's coming up. It
Mhm.
hasn't come up yet. Yes, you're seeing it?
Yeah,
We're seeing the Zoom.
just a minute.
All right. We just need to see the presentation now.
Yeah. You are able to see my screen?
Yes, we can see the screen, but not the presentation yet.
Yeah. Oh, yeah, I'm opening it now.
Good. There we go.
Oh, okay. Thank you very much, doctor. And I sincerely thank CCFP. And to be honestly speaking, I think I've not missed any CCFP webinars so far. So irrespective of the topic they do, Indus has always been with CCFP. And because of the topics, speakers, and the audience are awesome of CCFP. So, and this is a special year for Indus, doctor, this year, 2025. As you could see in the screen, we have completed 10 years in Jamaica. We launched in 2015 with 4 brands. And if I look back, we have almost many Caribbean countries in the last 10 years. We have introduced our brands. Of course, Jamaica was the first country and followed by Cayman, Bahamas, Guyana, Barbados, St. Kitts, and other countries also. We are there now. And it's specifically doctors from Jamaica gave the confidence for us. The amount of support we got helped us to reach out to other Caribbean countries. So today, I just want to refresh some of the OTC brands that we carry down in Jamaica and rest of the Caribbean countries. So one of the medication that we have for pain management, and it's a very popular brand down in Caribbean, especially in Jamaica also, which is basically our pain gel, which is Capsitop. And the highlighting point of this pain gel is that when we talk about gel for treatment of pain, the most common gel we all look into is diclofenac. But here, if you see the screen, we have a composition of different medications. The capsaicin is there. Of course, diclofenac is also there. Methyl salicylate is there. Menthol is there. The capsaicin is highlighting point of Capsitop because it is extracted from capsicum, nothing but the cayenne pepper that we eat, and is found to be really effective in depleting pain by inhibiting the pain triggering mediator, which is substance P. And diclofenac, we all know, also depletes pain by inhibiting prostaglandin. And methyl salicylate is basically a counter pain irritant. It also depletes pain. So if you look at it closely, these are 3 active medications which acts in different pathways, thereby pain is effectively controlled. Remember, this is a gel. So it has to be applied at the area of pain. And being it has the pepper extract, capsaicin, a caution is recommended not to rub or massage aggressive like any other gel that we normally do. And of course, we have to wash our hands thoroughly with soap. That is recommended. So that's our Capsitop. And there are a lot of studies available in capsaicin because that one ingredient many gels don't offer. We have German studies, French studies, and of course, it has been approved by US FDA for topical pain. That is capsaicin. So it has capsaicin, diclofenac, methyl salicylate, and Capsitop is over the counter. It's a 30-gram tube, price less than 1,000 Jamaican dollar. And the indication is some may say back pain, some may say neck pain, joint pain. Honest answer is all the above pain. This is a gel, and we have another medication, which is a spray. So we know the benefit of the spray. We normally spray it at the area of pain, and spray answer of action is very fast. Within seconds, the action kicks in. The highlighting point of this spray that you see in the screen, ready spray, is all natural. There's no chemical. It all extract from plants like eucalyptus, turpentine, methyl salicylate, menthol. So it's we all know the benefits of eucalyptus, turpentine. And of course, it has methyl salicylate and menthol also. So it's good for any sprain. My recommendation a day when you are at work, you can use a spray. And when you retire the bed, that time you can use the gel. You can gently apply the gel, Capsitop, and sleep. And daytime, this ready spray is very ideal. So we have another drug, which is for, as you could see in the screen, for acidity, gas problem, acid reflux, ulcer, associated pain, gastritis pain, the wonderful antacid, very popular in Jamaica and so in other Caribbean countries. This is the only antacid that offers the alginic acid benefit, which stops acid reflux. And How it stops acid reflux is very interesting. As you could see the clip, when person takes this antacid new gel, the alginic acid, one of the ingredient in new gel, interacts with the stomach acid and the foam is formed. And this foam is formed in just 4 minutes, and it blocks the stomach content moving from stomach into the food pipe. And this action of blocking continues literally 5 hours. After 5 hours, this raft, the alginate raft, is excreted completely along with the stomach content. When the person is ready for next meal, he can take the next dose of new gel. And it's sugar-free, safe in diabetes. Of course, it's safe in pregnancy. That's a highlighting point. So it has regular antacid medication to relieve gas and of course neutralize acidity and all. And we do extension of Nugel O. This is also over the counter basically. Additionally, apart from the alginic acid, is another interesting ingredient, which is oxytocin, which I have not come across any antacid currently in Caribbean. The oxytocin is similar action like lidocaine, but the thing is that oxytocin can be taken orally. It gives relief from gastritis pain instantly. For those who have, gastritis, ulcer, or stomach pain, the Nugel O is very good antacid. The only the contraindication is that pregnant mothers is not recommended, and kids less than 12 years, Nugel O is not recommended. For them, Nugel is good. Any non-pregnant women and of course kids about 12 years, Nugel O is good. So this is also over the counter by pharmacist. So you have to reach to the pharmacist and you should request them. Pharmacists will discuss with you and then they can dispense Nugel O. But Nugel, you can just pick it up from the shelf like water or vitamin pills like that. And the last product which I like to conclude today is our supplement, which is very popular. In fact, when I go to other Caribbean countries, they refer amino pep as a Jamaican tonic. Because whenever we go for work, they ask, where are you from? We say we are out of Jamaica. So sometimes we are labeled as Jamaican tonic, amino pep. Of course, the pack also remains our color, green and yellow. So it has interesting ingredients, as you could see, all amino acids, vitamins, and with minerals like zinc is there. Here, the topic today we have been discussing about sleep disturbance, sleep apnea, and one of the amino acids which has some benefit for those patients is tryptophan. Is also, suppose your sleep is disturbed due to stress. Tryptophan is a stress buster amino acid. It reduces the stress. So thereby probably it can promote sleep also for those who have challenge during exam or other times. So it has regular amino acids for immediate protein synthesis, and it has all vitamins, as you could see in the screen, plus zinc. It has 50 milligram, which is ideal for to boost immunity. And the composition has out of iron, so it's safe for sickle cell patients also. For samples, you can reach out to this WhatsApp number. So if anybody needs any of these samples, we'll organize to deliver it to you. Thank you very much, and please enjoy the rest of the presentation. Thank you, doctor.
Thank you ever so much. I can honestly say that we are very familiar with your products, and I'm sure that we all make good use of them. And would also like to thank Indus for their continuing ongoing support over the many years. I'm now going to invite Mr. Paul Russell. I saw him in the room. I'm not seeing him now for some reason. Oh yes, there you are at the top, right? From Abbott Nutritional, who are other sponsor for this evening, to say a few words to us. Mr. Russell. Not hearing you yet. Right, your screen is coming up. All right,
Hey,
see the app.
I'm supposed to hear you, but I'm not hearing you. Is your headset connected? Everything turned on properly? No, we're not hearing you. And I see that you're unmuted. Still not hearing you. You want to do an audio check for me using the audio settings on Zoom? It's all right. We're seeing the A. The share screen's working. But just come back to Zoom and do the audio check. You want me to stop your sharing? Probably help you a little.
Are you hearing me now?
There you go. Yeah, hearing it clear. So just share your screen again. I'll let
Okay.
you know when I see the Abbott A.
Okay. There's screen. All right. Seeing the Abbott A now?
Yeah, my brother. We're seeing it now.
Okay. All right. Good evening. Good night. My name is Paul Russell, and I'm grateful for the opportunity to present on some of Abbott's products at this CCFP webinar. Now, Abbott Nutrition has nutritional products that cover a wide cross-section of patients. We have products for the pediatric community, pediatric nutrition, cover adult nutrition, and therapeutic nutrition. So the first set of products we're going to be looking at is Ensure. And Ensure provides nutrition, it's gluten-free and suitable for lactose intolerance. The key is to identify the ideal Ensure for your patient's specific needs. So first up, we're going to look at Ensure Max Protein for patients who need additional protein, whether they're going to the gym, whether they're replenishing depleted protein stores, or they're just watching their weight. It has 30 grams of quality protein, 4 grams of fiber, and only 1 gram of sugar, and it's 150 calories per serving. And they come in assorted flavors. They're all gluten-free and suitable for lactose intolerance. So for patients who want a vegan-friendly presentation, there's Ensure Plant-Based Protein Shake. It's dairy-free, soy-free, with 100% plant-based protein. It has 180 calories, 20 grams of protein, and 5 grams of fiber. For patients living with diabetes, the nutritional solution is Glucerna. Glucerna contains a blend of slow-digesting carbohydrates that is clinically shown to help manage blood sugar response. Now, there are 3 presentations available in the supermarkets and in pharmacies. First, there's Glucerna Shake, 180 calories, 10 grams of protein. Then we have Glucerna Hunger Smart, which has 180 calories and 15 grams of protein. And there's Glucerna Protein Smart, which has 150 calories and 30 grams of protein. Now, all of these presentations have 4 grams of dietary fiber. They're all gluten-free and suitable for lactose intolerance. So for hard-to-heal wounds, whether they're internally or externally, there's Juven. And Juven can be used for pressure injuries, diabetic foot wounds, surgical incisions, and other acute and chronic wounds. Now, Juven is a medical food in the form of a powder, and it contains amino acids, arginine, and glutamine. It has hydrolyzed collagen protein. It has HMB, which is a metabolite of leucine. It has micronutrients, vitamin C, E, B12, and zinc. And this combination of ingredients support wound healing in as little as 2 weeks. You just mix 1 packet of Juven with 8 to 10 ounces of water or juice or any food, and it comes in orange and fruit punch flavors. So my last product that I'm highlighting today is Pedialyte. And it's just a reminder that in this summer heat that we're having, there's hydration for all. No longer is Pedialyte just for kids, but also for adults as well. So whether you're exercising, you're experiencing excessive sweating or extreme heat, or you have vomiting and diarrhea, stay hydrated with Pedialyte. So I've included my business card with my cell number, 489-6093, and it has my email address, which is paul.russell with 1 L at abbott.com. I spell my name with 2 L's, but in Abbott, there are 2 Paul Anthony Russells. So I have to have the one with the 1 L. And all our products are distributed by CareMed. So on behalf of my colleagues, Sandra Burke-Green, Genevieve Sidial, and myself, I want to thank you for the opportunity to present, and please enjoy the rest of the webinar.
Thank you so much, Mr. Russell.
Tequila.
And as
It's
always, we
tequila
thank you
with
for your
gin with
support.
um
Sorry, Mr. Heron, are you saying something? Okay. I think at this time that the CCFP promo was going to be shown at this time.
Why join the Caribbean College of Family Physicians, CCFP? Your pathway to professional growth, recognition, and global networking. As a member of the Caribbean College of Family Physicians, Jamaica chapter, CCFPJC, you become part of an elite network committed to advancing family medicine in Jamaica and across the Caribbean. Membership opens the door to local, regional, and international opportunities for professional development, accreditation, and leadership in primary care. Earn CCFP accreditation, recognition that counts. The CCFP-JC Education Committee delivers a 3-year curriculum tailored to the realities of family medicine practice in Jamaica. Achieve CCFP member accreditation by completing a minimum of 50 CME hours annually, 150 hours over 3 years, earning your accreditation certificate, a respected professional credential locally, regionally, and internationally. Access a rich calendar of CME opportunities, monthly workshops, seminars, and an annual family medicine conference. Monthly UW-IDEC CME meetings with certification. Online CME courses and training modules in collaboration with recognized regional and global health bodies. Tri-annual Pan-Caribbean conferences and WONCA International regional conferences. Diverse, high-quality educational content. Our CME programs cover clinical updates in hypertension, diabetes, obesity, HIV, AIDS, and occupational health, disease management guidelines from PAHO, WHO, CAREC, and CHRC, evidence-based approaches to disability management, patient safety, and community health, local, regional, and global connections, collaborations with the University of the West Indies, UWI, Caribbean Food and Nutrition Institute, CFNI, ACOM, ICOH, and other leading institutions. Opportunities to present and publish peer-reviewed research at regional and international conferences. Flexible CME credit earning. Members can earn credits through group learning, workshops, seminars, symposia, hospital grand rounds, individual learning, online courses, journal clubs, publications, presentations, and voluntary community work. A commitment to lifelong learning. CCFPJC members benefit from structured guidance, CME tracking, and annual submission of CME credits, ensuring compliance with the highest professional standards. Join the CCFP today, elevate your practice, expand your network, and gain the professional recognition you deserve. Contact the Secretariat to start your membership journey.
Thank you very much. And I do encourage all our colleagues who are online who are not yet members of the CCFP to become members. As you can see, there are many benefits above and beyond the CME hours that you can gain. So now we come to our second presentation for the evening, and it is my pleasure to introduce to you Dr. Jordan Eaton, a graduate of Campion College, he says that proudly, who studied medicine at the University of the West Indies, where he completed his undergraduate degree in 2014. He then went on to junior and senior house officer years at the University Hospital of the West Indies and the Kingston and St. Andrew Health Department, before working as a medical officer in psychiatry at the Kingston Public Hospital. He subsequently returned to UWI for DM Psychiatry, which he completed in 2023. His DM project on patterns of referral to the consultation Liaison Psychiatry Service at UHWI was awarded Best Overall, Best Student, and Most Impactful Poster Presentation at the National Health Research Conference in 2023. He has also helped to write several papers on psychedelic mushrooms in treating mental health conditions in Jamaica and currently works as Senior Registrar in Psychiatry for the Spanish Town Hospital and with the St. Catherine Health Department. We welcome him this afternoon to speak on the overlooked connection, sleep apnea, and women's mental health. Dr. Eaton, over to you.
Thank you so much, Dr. Goldson. Good evening, everybody. Just want to make sure that you guys can hear me okay. Seems to be good.
Yes, we are here.
And
I'm
we're
hearing
seeing
and we're seeing
presentation.
your slides.
All right, fantastic, no problem. So we are going to talk about a topic that is actually quite interesting and near to me. My mother and the two friends, when they heard I was going to be presenting on this topic this evening, they said, "What are you presenting on?" Sleep apnea and mental health in women. And all three of them looked around the room and I said, "So you mean all three of us? You're going to use all three of us as your case presentations, because that's all three of us." And we had a grand laugh about it. So we're going to have a little bit of fun with this presentation and try to take a very serious topic and make it a little bit easier in terms of just going through. So I like to begin everything with just an outline. So we're just going to do a brief overview, the epidemiology, proposed mechanism, mental health impacts, outcomes, and the summary. And thankfully, Dr. Baker did a phenomenal job on the pathophysiology. So I'm not going to spend too much time going through that. I'm just going to highlight one and two things of specific interest. So a nice summary following up on what Dr. Baker said. Obstructive sleep apnea falls under the sleep disorder breathing, episodes of reduced or no breathing resulting in hypoxia and tissue hyperperfusion and waking from sleep. It can lead to tissue inflammation and subsequently tissue death. Women specifically are affected by gonadotropic hormones as well as pregnancy-related hormones, and it makes them particularly susceptible to having sleep pathology. So why are we focusing on women specifically in this presentation? The reason being, historically, that is an under-recognized group of patients. Men are more likely to have loud snoring and weakness apnea episodes. Women, however, are less likely because they have a different symptom profile: insomnia, fatigue, mood changes. And as Dr. Baker said, it's estimated that over 90% of women with sleep apnea may be undiagnosed. And you can see those symptoms are very vague and non-specific: insomnia, fatigue, mood changes, depending on the phase of life that that patient is in, pre or post menopause, or even perimenopausal, depending on their particular medical history or family history. Sleep apnea may not be something that even enters the mind of us when we are seeing these people. And we just think, no, he didn't sleep well. You just need a good night's sleep. It's fine. You just slept, but you do better tonight. So it is very topical. So the question becomes, how many? It is one of the most common sleep breathing disorders. It is estimated that 25% of women are at risk in the US for obstructive sleep apnea. So that means we're looking at a prevalence of about 1 in 4. And the problem is the high risk for obstructive sleep apnea syndrome or symptoms are associated with a higher prevalence of chronic illnesses compared to the low risk patients. So again, we see the interplay between the conditions that are predisposing us to obstructive sleep apnea, and at the same time, the pathophysiology of the obstructive sleep apnea is worsening the underlying condition. So it's a very vicious cycle that we're looking at. Heart disease, arterial hypertension, diabetes, and PCOS, with something which our particular Afro-Caribbean women do deal with a lot of issues. See it a lot in psychiatry as well, either as an exacerbating factor or a complication of something else. So it's something that we need to consider. What are the common symptoms of obstructive sleep apnea in women? Habitual snoring, 61%, sleep onset insomnia, 32%, and maintenance insomnia symptom, 19%. And I'm just going to take a pause to clarify, because we do speak about the different phases of sleep. So you have onset or induction, and then the maintenance of sleep, which is where you have REM and non-REM sleep. and then you're fade out to where you're waking up. So you can have pathologies at the different phases of sleep. So the sleep onset insomnia refers to the first part of that graph where you're trying to fall asleep. So this is the time when the patients are saying, oh, you know, I just can't get my brain to turn off. No matter what, I just not falling asleep. When I do fall asleep, I will sleep, but the problem is always falling asleep. So I have to take something to help me fall asleep. Contrast that with the maintenance insomnia symptoms, wherein the patient will fall asleep very quickly, but to maintain the sleep for the duration of that time is difficult for them. So they'll wake up 3, 4, 5 different times in the night. And yes, they are sleeping for 8 hours, but it is not restful and or restorative sleep, which also leads us to daytime sleepiness. 24% of patients, you can have 7% with observed apneic spells. One of the more interesting ones is body movement, the twitching, the legs that are jumping, the arms that are jumping, the body movements when the person is sleeping. And 33% have the restless leg syndrome symptoms. So again, if we're not thinking broadly, we are going to miss these things because we can easily say, oh, it's a one-off, or we can downplay what the patient is experiencing, and we can miss the pathology. So for women specifically, the prevalence rises after menopause, pregnancy, and PCOS, all of which are high-risk states. Pregnancy, obstructive sleep apnea, gestational hypertension, preeclampsia, gestational diabetes, all associated with the two. 35% of women who are postmenopausal, high risk. 21% of women who are perimenopausal, high risk. 23% of women who are not near menopause, high risk. So again, you can see based on the different studies, the range for incidence is roughly about, averages out between 1 in 4, about 25%. So with pregnancy specifically, oh, sorry, no, just did that. So we therefore have an idea specifically in women what is causing this pathology, hormonal as a possible cause. The progesterone increases ventilator responsiveness to hypoxia and hypercapnia. Estrogen and progesterone are protective against obstructive sleep apnea due to their effects on dilatation of the upper airway. The premenopausal period is the lower risk or the lowest risk, and postmenopausal is the highest because of the change in the hormonal concentrations in patients' bodies. And again, PCOS, high androgen state, it increases the risk in premenopausal, and hormone replacement therapy decreases the risk in postmenopausal women. So I did glimpse a question earlier in the question and answer. I'm not sure if it had been answered as yet, but to clarify, hormone replacement therapy for women who are peri and or postmenopausal and do not have risk factors that would preclude them from getting hormone replacement therapy. For these women who have a predisposition towards obstructive sleep apnea or who already have obstructive sleep apnea, hormone replacement therapy would help to improve their symptoms because it would return their biochemical state to almost a premenopausal state where you have lower risk factors. So, on to the meat of the matter. Mental health implications, because that's what I want to focus on. And I am going to try and be concise, just focused interventions and focused presentations in terms of symptomatology. Now, when we look at medical comorbidities overall and obstructive sleep apnea, we see when comparing the obstructive sleep apnea versus the non-obstructive sleep apnea patients, you see that those with obstructive sleep apnea have a high risk of conditions. And I want to point out that the highest being hypertension. Sure, we can see that. However, sorry, let me see if I can get this thing to go off the bottom of the screen. But yes, so when we look at here, depression is 41, which is second only to hypertension. So it speaks to how common it is in terms of patient presentations. So focusing specifically on depression, Kaufman et al. In 2017 looked at about 5,500 patients from 264,000 individuals who participated in this study, right? They were diagnosed with obstructive sleep apnea, and they compared those without sleep apnea, those reporting past year sleep apnea. And what they looked between them and the controls is that they had a 3.1 times increased odds of having depressions and a 2.75 times increased odds of suicidal ideation. And I want us to just reflect on that for a moment, that if 1 in 4 women are having this condition and 90% of these women are undiagnosed, there's a distinct possibility that many of these women are walking around not only with moderate to severe depression, but with frank thoughts of suicide. And this is all coming from not sleeping effectively, efficiently, restoratively. And that concept is wild to me, right? Depressive status, 47.4% associated in obstructive sleep apnea, according to Daya et al. And Pinter et al. Found an 80% prevalence of depression. And again, coming close to 1 in 5. So we see that the numbers are quite high. And how we know that the two are interconnected is that Hovitz et al. In 2014 did a study, and they looked at the effective treatment of obstructive sleep apnea on depressive symptoms. It was a systematic review and meta-analysis, and they found 19 trials within the literature. And what they concluded at the end of it is that persons who were using CPAP machines or MADs, which are mandibular advancement devices that push the jaw forward to try and keep the airway patent, they were effective in reducing the depressive symptoms in these persons who had obstructive sleep apnea. So these patients didn't even need psychopharmacology or talk therapy. Once they were treated for the obstructive sleep apnea, their depressive symptoms resolved on their own. And we know that I can't mention depression without mentioning anxiety or panic because their pathophysiology is almost identical. Obstructive sleep apnea is linked with higher anxiety symptom burden, nocturnal hypoxia and sleep fragmentation, increased arousal, and sympathetic activity. So what will happen is that the patient will have an apneic spell, and it will not only interrupt their sleep, it will give them an exaggerated response and a flood of catecholamines that will therefore make it harder for them to go to sleep, further disrupting their sleep cycle. Panic disorder is an extreme pole of it, but it is associated with recurrent panic attacks. And in 2015, Su et al. Noted a few small studies that looked at panic and specifically obstructive sleep apnea. There was about 8,700 patients versus 34,800 controls. And what they noted was that there's a predisposition of patients with sleep apnea to developing panic disorder. And the hazard ratio for subsequent panic disorder among the sleep apnea patients was 2.7. So again, we are seeing the associated increase. When you look at obstructive sleep apnea, depression, and anxiety, depressive and anxiety symptoms were present in 15 and 14% of patients with obstructive sleep apnea, respectively, according to Lee et al. Right? The prevalence of these symptoms did not differ between obstructive sleep apnea and control symptoms. Severe obstructive sleep apnea was less likely to be related to depression and anxiety than mild obstructive sleep apnea. And subjective sleep apnea symptoms were positively correlated with depression and anxiety symptoms. Now, one thing that Dr. Baker mentioned, and I am going to come back to it specifically, is the neurocognitive changes. And yes, we identified that one of the proposed pathophysiological associations of depression, anxiety, and obstructive sleep apnea has to do with a hormonal mechanism, specifically in women, associated with the perimenopause and menopausal changes. But what we also need to recognize is by the pathology of the recurrent hypoxic spells, you are entering a period of time where you are creating the setup for neuroinflammatory changes in the neural tissue. And while it may not result in full-on ischemia, recurrent neuroinflammatory changes can trigger responses within the body and lead to neurocognitive changes. So when we consider that it is highly prevalent in patients with Alzheimer's dementia, it makes sense. Emerging evidence that obstructive sleep apnea is a risk factor for preclinical Alzheimer's dementia, meaning that if you have obstructive sleep apnea, you are at an increased risk of having Alzheimer's dementia before it is picked up. So it is a significant risk factor because of the neuroinflammatory changes. It has been associated with MCIs. I am going to remember what that is in 1 second, and I will come back to it, I promise you. My brain has left me for a second. But some studies reporting 25% prevalence of cognitive dysfunction associated with obstructive sleep apnea. It is a recognized factor that negatively influences risk, manifestations, and possibly the progression of Alzheimer's dementia and other forms of dementia. And again, taking a pause for the cause to bring it to Jamaica, I want us to remember that Professor Eldemar Sherrill's paper, I believe it was 2013, identified that the predominant picture of patients in Jamaica with dementia are vascular dementias, which are at risk from obstructive sleep apnea. And the second was a mixed picture of Alzheimer's dementia and vascular dementia. Alzheimer's dementia, which is increased with the risk of obstructive sleep apnea. So you are increasing your odds in multiple ways from your cognitive issues. Sleep breathing disorders, such as obstructive sleep apnea, are associated with higher risk of cognitive impairments in older women. The common finding in several of these studies is decreased hippocampal volume. Other affected areas of the brain include the frontal and parietal lobes, which show focal reductions in gray matter. And it is associated with the development of MCI or Alzheimer's dementia with symptomatic patients, but who have a higher likelihood of associated sleep disturbed impairment causing it. So again, just a few more studies to show the connection between the two. So the question becomes, what can we do about it? Obstructive sleep apnea is associated with multiple medical conditions and mental health conditions. And multiple studies show that these conditions improve and the risk factors are reduced with CPAP or mandibular advancement devices. Women still remain less likely to be assessed as having obstructive sleep apnea because of variation in the symptoms. So again, the habitual snoring is pretty common, but it's not very common in women. You're more likely to see the insomnia type symptoms, the daytime sleepiness, the body movement disorder, and the restless leg syndromes for the presentation for women. So we can ask some of these questions. And anybody who knows me knows I love a screening tool. The Berlin questionnaire, it is 10 questions plus the body mass index. And at the end of it, it gives you low, medium, and high risk for obstructive sleep apnea. So you can use this for patients to send them for polysomnograph testing to confirm the diagnosis of the sleep apnea. The Stop Bang questionnaire also does it in much the same way. The issue with these is that they are not as sensitive in picking up symptoms in women. So we do need to use them judiciously, and it comes back to how we are approaching and managing and having a index of suspicion that says to us, we need to think about this. So what we also need to do for our patients who may be waiting for the testing or are waiting for the CPAP machine or are having a suboptimal response to the mandibular advancement devices or complications is we need to screen for our mental health conditions. And again, we keep it simple: depression, anxiety, cognitive assessments. Those are the three things that are majorly associated with obstructive sleep apnea. So for depression, we're looking for 5 of 9 symptoms for 2 weeks or longer. For the anxiety-related symptoms, you're looking for excessive and inappropriate work for 6 months or longer. And for the neurocognitive assessments, you can do a complete higher mental status exam, or we can use the easy way. Again, screening tools, we know them, we love them. The first is the PHQ-9 for depression. 9 questions, 3 is a maximum score, spits out a number at the end of it that gives you a clinical correlation. Makes it very easy. Don't want to use the PHQ-9, you can use the PHQ-2, you can use the Beck's Depression Inventory, or you can use the Hamilton Depression Rating Scale, all of which are available online for free. Easy to use, easy to access, little to no issues in terms of administration. Again, the GAD-7, 7 questions for anxiety. If you don't want to use GAD-7, you can use the Hamilton Anxiety Index, or you can use the Beck's Anxiety Inventory. Gold standard for screening for cognitive impairment, the mini mental status exam. A lot of people confuse this with the mental status exam. It is a common enough mistake. Let's clarify very quickly. The mental status exam is the gold standard exam for, or the actual clinical exam rather, for examination of patients with a suspected psychiatric condition in terms of thought form, thought content, hallucinatory symptoms, etc. That is used for patients with depression, bipolar, schizophrenia, etc. The mini mental status exam is a screening tool that we use when we are looking for cognitive impairment for older patients who we suspect have a condition like Alzheimer's dementia or vascular dementia. And again, it is only one of several cognitive assessment screening tools that we can use. This is just usually one that people are most comfortable with. And again, free to access online, spits out a score at the end, and it can give you the clinical interpretation to give you some additional guidance. In terms of treatment, CPAP is the first line for moderate and severe. It improves the mood, it improves daytime function, but adherence is critical. And I can tell you firsthand, it is difficult for some patients to be consistent with the CPAP machine because it does take some getting used to. You treat comorbid insomnia with cognitive behavioral therapy specifically for insomnia, as Dr. Baker had mentioned earlier. You can address their weight, their PCOS, perinatal issues. All of those issues can be also done concurrently. It is the risk of sleep apnea increases in pregnancy, and it is linked to hypertensive disorders of pregnancy, and the sleep fragmentation may worsen the perinatal mood disorders. So for our patients who are at risk, we need to consider screening them either for the obstructive sleep apnea or following them up a little bit more closely in terms of psychiatric symptoms. So I've spoken for far too long. Let's just get the whole kit and caboodle and get on out of here. So the clinical approach, we're going to do practical steps. We need to be suspecting these conditions for our patients. We have to be thinking broadly and excitingly. It is more common than we anticipate. We need to ask targeted questions: insomnia, unrefreshing sleep, witnessed apnea spells, morning headaches, nighttime gasping. Use the screening tools, but also consider if the patient can get home sleep testing if it's available, or the PSG, the polysomnograph. I want to say that it's done at Andrews, but I do not recall off the top of my head. We can confirm. And we screen the midlife, the perinatal, and psychiatric patients, and we collaborate with sleep medicine. We need to treat obstructive sleep apnea and the comorbid insomnias for best outcomes. And sometimes we have to treat those comorbid insomnias with underlying psychiatric medication that we use to treat underlying depression or underlying anxiety that are coming from the obstructive sleep apnea. Thank you so much. Hopefully I was not too long.
Thank you so much, Dr. Eaton. Very effective use of time. You certainly made the case very clearly for the link between obstructive sleep apnea, the increased risk for both depression, suicidal ideation, and also the anxiety. And you pointed out that the treatment of the obstructive sleep apnea can help to decrease the symptoms of these conditions. It was also useful that you reminded us of the many screening tools that are freely available to screen for different conditions that can then guide us to go on to more definitive studies to make the diagnosis. So thank you very much. There are some questions and answers in the question and answer tab, and you are still in the audience able to add questions there if you would like. I know that 2 of the questions have been answered, and those persons who asked can look in the tab to see the answers that Dr. Baker had typed in there. There was a question from Dr. DeCooler asking, are smart devices, phones, watches helpful in diagnosing sleep apnea? So, Dr. Baker, would you like to take that question?
Good evening once again. There has been over the past 5-10 years a market increase in these smart watches, smart devices, sleep apps that are available that I will confess I have tried using a sleep app or two myself just to see how it works. So while it is that they may not diagnose sleep apnea, they may, some of them, the better ones, actually give us an idea of what is happening to us during sleep and may then direct us to have a sleep study or to have the discussion with our physician, and from there be referred for a sleep study. So the smart watches, the devices themselves don't diagnose. They're not FDA cleared or approved by any of the, whether the AASM, which is American Academy of Sleep Medicine, or the European Association of Sleep Medicine, but they certainly do offer useful information. The caveat with that, though, is that they themselves may cause an anxiety associated with sleep. So just like how you have a patient with hypertension who checks their blood pressure 3-4 times per day or every day, and you're saying, well, you don't need to check your blood pressure that often. You do have persons who have these watch devices that they're looking at it. You have to question the accuracy. My oxygen level drops to 35% during sleep. So I advise to use with caution, but there is, they can be useful in helping to determine if there may be something that needs to be further investigated. I'd just like to use the opportunity, Dr. Standard Wilson, to say that for sleep apnea investigations per se, obstructive sleep apnea, that the home sleep tests have been approved and have been approved for years. We have over 80 different types of sleeping disorders. As I said, this obstructive sleep apnea is the most common one. Time before, we would have to refer the person to a sleep lab where they stay overnight and they're hooked up to all sorts of devices, and they stay overnight in a lab, and you have a technician who is watching them and doing the recording. However, for investigation of sleep apnea, you do have the validated devices, and we have them available here in Jamaica, and they're getting smaller and smaller, and the patient takes them home. They do the investigation, it's sent to the dashboard. I do them to my office, and quite a number of persons are coming in, and it's done at the person's convenience and at home. Thank you.
This is something that they would get from the pulmonologist, the whole test. Not something over the counter, so to speak.
It's not over the counter, so to sleep. I know I do sleep studies. Dr. Paul Scott does sleep studies. He does, I think he has a lab. I don't think he does a home-based sleep test. Dr. Toller-Reed also does sleep studies. And there is a new group, ISD Health, that also offers sleep studies. So ISD, Dr. Toller-Reed and myself, we do the home-based study. Dr. Paul Scott has an actual sleep lab where the person stays overnight. Yeah, that is particularly useful if we're dealing with complex cases and we're not looking only for sleep apnea, but other conditions, sleep disturbance, sleep-related disturbances as well.
Right, and you have answered some of the other questions that were here. Someone has asked you to clarify the role of HRT in managing sleep apnea. I think you had mentioned you wouldn't use it primarily for treatment, but it could be an adjunct. Am I correct?
Yes, and Dr. Eaton, in his very, very comprehensive and quite interesting presentation, did mention HRT as well, that in a select group of persons who are at risk or perimenopausal or menopausal women in whom the decrease in estrogen and progesterone can definitely contribute to OSA and the symptoms, and particularly the neurocognitive symptoms, that this may be an adjunctive therapy for those patients.
Right. And someone is asking about the affordability of the CPAP machines. And also at the same time, whether there is better compliance with the newer CPAP machines. Because I know some of the older ones, as you mentioned, were quite bulky and uncomfortable. And I must say, I myself used it for a while and then stopped. But after hearing tonight, I'm thinking that I need to be reassessed. But what are your thoughts on that? The affordability, and are the newer ones easier to use?
So in terms of the affordability, and let me use the opportunity to say that we're moving from a CPAP, which CPAP is continuous positive airway pressure, easier to say CPAP. We're using more APAPs, which is an automated positive airway pressure. And what these machines, they still deliver positive airway pressure. As I said, that just acts as a splint. And somebody had asked if using the device, the snoring disappears, and the snoring does disappear. So everybody's happier, bed partner, persons at home, because the snoring now goes. But the APAP versus the CPAP, the automated devices, they operate within a range. So they can detect whether or not a person may need a higher pressure or a lower pressure, depending on their position in bed, depending on whether they may have nasal congestion or not. In terms of the affordability, the prices are still for many persons a challenge. Let me just put that way, a challenge. I will say that there are a group of us who have been trying to advocate with some of the insurance companies, because the insurance companies will offer a compensation or copay, but they offer after the person has already purchased the machine for moderate or severe OSA, and then they will reimburse a portion of the cost. What we're trying to do is to say to them, hey, instead of waiting until afterwards, why not, once a person has their reports, etc., meets your criteria, why not offer it upfront? So that is still a work in progress. We're hopeful because you do have other, Sagicor and all of the major players in Trinidad, for example, they offer payment pre-authorization of the machines. The machines here in Jamaica would cost more than if purchased, say, online or overseas. But I caution persons because some of the persons that actually sell the machines here offer a follow-up plan. And as you said, Dr. Standard Goldson, using the machine can be a challenge. So if you have that support behind you, you can go in and change masks, because the mask that one person wears may not be suitable for next person, not just size, but the whole design of the mask. So while it is a number of persons get their machines from overseas, there are benefits in terms of getting it here because of the support that is offered from the companies here and the warranty and actually the follow-up. In terms of the masks and the machines, they've gotten smaller, they're quiet, they are easily, you have very small machines that are portable, but even the standard machines now, you see persons all the time in the airports with them. You may not recognize that they're CPAP machines. I do, because I know what they look like. But just to say that most of the airlines allow patients to carry their CPAP devices in their cases on the aircraft, and it is not counted as part of their carry-on luggage. So it is a medical device, they can travel with it. They are more quiet. The masks have become, anything from nasal prongs, nasal pillars, just a nasal mask, a smaller mask. And I will say I returned from a sleep conference. You actually have sleep conferences dedicated to nothing else but sleep. I went to the one in Seattle this year, and the masks that are coming out are getting smaller and smaller. So we're making strides.
Wonderful, good to know. I am not seeing any other questions. I don't know if anyone wants to put in any other questions. I If not, we are going to bring proceedings. We are going to move along. I think we've had a very good evening. Both Dr. Baker and Dr. Eden have shared a wealth of information with us, which is relevant to our day-to-day practice. I'm seeing Dr. Brown Morgan with a hand up. Yes, Dr. Brown Morgan, you'd like to ask a question or make a comment?
Yes, I wanted to ask Dr. Baker a question about
Sure.
the use of the HRT. I wanted to know if you could use the prolactin, estrogen, progesterone, if you could use progesterone alone, and if that would help in people who had sleep apnea, which was hormone based, because there's so much that is associated with using the estrogen in postmenopausal women, and if there was a time limit to using it. Thank you.
And that is an excellent question, Dr. Brown Morgan, and I will be the first to tell you because it is interesting. Just earlier today, a friend of mine was asking me about hormonal replacement therapy, and I will defer to the gynecologist about it. We do know it is appropriate, but for a select group of patients, and that's where it is. It has to be monitored. We do know that there are issues, as you said, with estrogen replacement. You do have subgroups of patients in whom it is not recommended. There's an increased risk for some in terms of malignancy, and increased risk in some in terms of thromboembolic disease. So it may not be the answer for everyone. The estrogen and progesterone actually operates on a physiological basis. They impact the respiratory system differently. So the estrogen may cause a the progesterone may cause an increase acts as a respiratory stimulant, so may cause an increase in terms of breathing, whilst the estrogen acts at a different level. So it may be suitable for some patients for a portion of time. It is not looked at as the final and the first option of treatment, but as an adjunctive therapy and for a limitation of time. But for my patients, I will refer them to the obstetrician gynecologist or gynecology colleagues for HRT. And this underscores as well that the whole aspect of sleep apnea, obstructive sleep apnea, is multifactorial. You have the pulmonologists, you have the psychiatrist. That had a patient in my office who I've been seeing her for months. And I'm trying to tell her that a lot of her symptoms are sleep related, but I still think you need to see a psychiatrist because of the overwhelming anxiety and depression symptoms she's having. So it's not just a one specialty. It really takes a whole cohesive effort for many of our patients to get them to where we want them to be. Thank you.
Dr. Eaton, if I may ask you, you mentioned that often persons with depression and anxiety may have underlying obstructive sleep apnea. Do you recommend general screening, specific screening? How would in your patients with depression or anxiety?
So it depends. Sleep disturbance is one of the most common symptoms that we see in depression. So what we're going to have to be doing, because even in doing this presentation, I've had to reconceptualize within my own mind how I'm going to be assessing my patients. So we have to look for the risk factors. If it is that we as psychiatrists are seeing patients who have depression and anxiety, but we notice that they're women, they're complaining about significant sleep problems. We as a psychiatrist can dive further into the sleep pathologies themselves. So it is that we have to have that index of suspicion, and we have to just start asking the questions, to be honest.
Thanks very much for that. And I do want to thank both yourself, Dr. Eaton and Dr. Baker, for the presentations this evening, but I will not steal the thunder from the Secretary of the CCFPJ, Dr. Dane Levy, who is tasked with giving the formal vote of thanks. So at this time, I'll hand over to Dr. Levy.
Thanks, Aileen. Good night, everyone. I must say, just at the beginning, that this has been a wonderful evening. Very, very informative presentations, very detailed, very informative, very helpful. But let me get to the task at hand, and that is to say thanks. And let me thank you, first of all, Aileen, for handling this webinar, this conference so ably, and having us so efficient, being so efficient with the timing of it. So we got so much out of it, and it was so efficiently done. Thank you so much again. Also, I would like to thank Dr. Arna Brown Morgan. She led us in prayer, and prayer that was really very well done, very apt for the moment. And of course, I think her prayer was answered because she asked that we would receive knowledge of these of this particular sleep apnea issue, which is based on what we have learned this evening. It might very well be another epidemic in terms of the diagnosis, if it is to be properly diagnosed. 25 with the statistics that were given by our presenters suggest that this is of high incidence and that we should be more alert and on the lookout for this particular condition, which has so much consequences to the health of our female population and the mental health of all. I'd also like to say thanks, of course, to our president of the Jamaican chapter of the Caribbean College of Family Physicians, Dr. Seni Onanujo, in her opening remarks, which she handled very, very well, as she usually does, and being comprehensive in this in these opening remarks and introduction to this well-organized conference this evening. Our presenters, Dr. Terry Baker, consultant pulmonologist and SMO of the National Chest Hospital, and Dr. Jordan Eaton, psychiatrist, did exceptionally well. Dr. Terry Baker, of course, presented on the effects of sleep apnea on women's health, and Dr. Jordan Eaton, psychiatrist, presented on his specialty, mental health and sleep apnea. And both presentations were exceptionally well done, very informative, very comprehensive, and I think it stirs our interest some more, and of course our responsibility to look a little more at these issues when it comes to making a proper diagnosis and seeking help if we have a high incidence of suspicion, of course. Thank you again, Dr. Terry Baker and Dr. Jordan Eaton for your presentations. Exceptionally well done. Thanks again. Of course, our conference this evening could not have been put on without our sponsors, Indus Life Sciences and Abbott Pharmaceuticals, who both had a chance to speak on and present their products to us, which are very applicable to the mental well-being and the health, of course, of our population. I think they want to thank them for their support, their continued support, and we just want to encourage them to continue to support the Caribbean College of Family Physicians in our presentations, in our webinars, and in all our continuing medical education presentations. We are really very thankful for your support, and we encourage you to continue to support us. Our administrative team, led ably by Mrs. Lynn Thompson Hyatt and our background staff who support her, they, of course, did a wonderful job as well, efficient job in getting this conference well organized and presented. Our technical team, headed by Sam Heron from Old Gate Solutions, of course, again, did an exceptional job. Sam is someone who we can depend on and his expertise and his command of the technical aspects of the presentation were very evident this evening again. So generally, thanks to all the participants as well. I did not get to see exactly how many participants were on, but I'm sure everyone that was on would have learned quite a bit and would have been very thankful for the presentation this evening. I myself am very thankful for it too, and thought it was very, very well done, very well organized. And of course, before I go, just want to encourage our participants. The ads that were put on by the Caribbean College to highlight the importance of the continuing medical education, of being a part of the Caribbean College of Family Physicians, the benefits of membership, and the benefits of obtaining the MCCFP. I think those are very well highlighted, and we look forward to you joining us in and becoming members of the Caribbean College of Family Physicians. So thanks again. I think we've had a wonderful evening. I think we've had a very informative, educational evening. And just to say thanks to all that have participated in this evening and all who have worked towards making it such a success. Thanks again on behalf of the Caribbean College of Family Physicians Jamaican chapter. Good evening to you.
Good evening to you all. We did have over 170 persons at peak, and we thank you for taking the time out to be with us. Godspeed to you all.
Why join the Caribbean College of Family Physicians, CCFP? Your pathway to professional growth, recognition, and global networking. As a member of the Caribbean College of Family Physicians, Jamaica chapter, CCFPJC, you become part of an elite network committed to advancing family medicine in Jamaica and across the Caribbean. Membership opens the door to local, regional, and international opportunities for professional development, accreditation, and leadership in primary care. Earn CCFP accreditation, recognition that counts. The CCFPJC Education Committee delivers a 3-year curriculum tailored to the realities of family medicine practice in Jamaica. Achieve CCFP member accreditation by completing a minimum of 50 CME hours annually, 150 hours over 3 years, earning your accreditation certificate, a respected professional credential locally, regionally, and internationally. Access a rich calendar of CME opportunities, monthly workshops, seminars, and an annual family medicine conference. Monthly UW-IDEC CME meetings with certification. Online CME courses and training modules in collaboration with recognized regional and global health bodies. Tri-annual Pan-Caribbean conferences and WONCA International regional conferences. Diverse, high-quality educational content. Our CME programs cover clinical updates in hypertension, diabetes, obesity, HIV, AIDS, and occupational health, disease management guidelines from PAHO, WHO, CAREC, and CHRC, evidence-based approaches to disability management, patient safety, and community health, local, regional, and global connections, collaborations with the University of the West Indies, UWI, Caribbean Food and Nutrition Institute, CFNI, ACOM, ICOH, and other leading institutions. Opportunities to present and publish peer-reviewed research at regional and international conferences. Flexible CME credit earning. Members can earn credits through group learning, workshops, seminars, symposia, hospital grand rounds, individual learning, online courses, journal clubs, publications, presentations, and voluntary community work. A commitment to lifelong learning. CCFPJC members benefit from structured guidance, CME tracking, and annual submission of CME credits, ensuring compliance with the highest professional standards. Join the CCFP today, elevate your practice, expand your network, and gain the professional recognition you deserve. Contact the Secretariat to start your membership journey.